that medicine anticipates the corpse is kind of morbid, and it seems strange at first to me. Modern medicine, after all, is characterized by nothing if not teams of people working with great energy and at great cost to keep people alive. How can that activity be oriented to death? But once I understood Bishop's morbid idea, it did not seem so strange. In fact, I see evidence for it everywhere. So as Lydia said, modernity's, she talked about the four causes. Modernity is characterized by a progressive loss of confidence in formal and final causes for living beings. With respect to human beings, our formal cause can be thought of as that which makes us the particular sort of being we are. Our final cause, that purpose or end, that telos, toward which we are directed. In modernity, such causes seem to be merely subjective cultural attributions, and to that extent arbitrary and more or less unreal. Modernity directs attention to the causes that remain, material causes, that of which we are made, and efficient causes, that which brings about an effect or motion in us. And importantly, such are the causes that science can know and technology can control. The history of medicine includes this shift of attention and confidence from formal and final to material and efficient causes. Bishop picks up that history in 18th century France, where Foucault's, of course Foucault wasn't in the 18th century, but where his famous clinic and his analysis emerged. There, patients were subjected to a new and penetrating medical gaze, which presumed to use knowledge gained from the new sciences of chemistry and physiology, and especially anatomical dissection of corpses, to see through the fuzzy pretense of the living patient to the sharp reality beneath that pretense. And the reality was and is the dead body. The body as it is known through dissection and through scientific abstraction. In this sense, Bishop proposes the dead body became epistemologically normative for medicine. Medicine's knowledge of the living was derived from the dead body as an ideal type. The dead body is still idealized in the first parts of medical training, which traditionally begins with dissection of a dead body to ground students' knowledge of bodies that are living. That idealization is carried forward in the clinical interview, where the physician seeks to map knowledge gained from the dead body onto the living. The patient, Bishop suggests, is questioned by the doctor in much the same way that the corpse is questioned by the anatomist, or in much the same way that the functioning body is questioned by the physiologist. Now, to this point, Bishop joins others in critiquing contemporary medicine for giving in to a scientific reductionism that turns the patient from subject to object, turns the clinician from genuine concern to detachment, and thereby alienates patient and clinician from each other, and alienates both from contemporary practices of medicine. That critique has been leveled from many quarters, often in the name of a more humanistic, patient-centered, holistic medicine. But Bishop makes a deeper, more difficult, and more consequential claim. Namely that because medicine has given up formal and final causes for human being, even its efforts to overcome scientific reductionism fall prey to this metaphysics of efficient causation, which includes a kind of nihilism regarding what it means to live and die well. And in a metaphysics of efficient causation, human being has no intrinsic telos, but only a terminus, the dead body. As a result, the dead body becomes not only the ground of medical knowledge about the living, but the goal toward which practices of medicine aim. When medicine is guided not by any human telos, but only toward our final terminus, medicine becomes captive to a second aspect of the metaphysics of efficient causation, a politics of efficient control. Bishop points to the famed physiologist Bernard, who dismissed questions that ask why, in other words, questions about formal and final causes, as not befitting human capacities. Rather, ask how, Bernard insisted. Because knowledge of how, knowledge of efficient causation, gives us power to make things happen. A metaphysics of efficient causation, which Bernard championed, requires no justification for an action other than that the action achieve its effect. For Bishop, the intensive care unit serves as a paradigm expression of this metaphysics of efficient causation and its politics of efficient control. In the ICU, clinicians mobilize an army of supporting technicians and an arsenal of sophisticated technologies to keep the human matter in motion. The effectiveness of each action is not judged in relation to whether the action is congruent with some formal or final cause for the human being in question. After all, who can know what those are? Rather, the action is effective if it has an effect, e.g., restoring cardiac output, removing electrolytes from the serum, or oxygenating the blood. Patient life in the ICU is thereby reduced to physiological functioning. The patients and even their diseases disappear. All is matter in motion. Clinicians and patients alike experience the physiological medicine of the ICU, as most all of us who are in work in that area know, experience that as both degrading and unsufferable, often even as life worse than death. But what to do? If human being is best understood as merely the movement of matter that anticipates the corpse, medicine struggles to find non-arbitrary reasons to stop its efforts to keep that matter in motion. Actions are not futile so long as they achieve their effect, and if their effect is to keep matter in motion, they remain effective until the patient manages to die despite them. Physiological medicine, therefore, seems locked into a set of practices that tend to the bizarre and dehumanizing. To remedy this situation, medicine makes what Bishop calls the discursive turn. In reaction to the coldness of technological medicine of the ICU, medicine turns to an interdisciplinary array of experts to provide a kinder, gentler, more comprehensive approach. The result is what has come to be called biopsychosocio-spiritual medicine, the medicine that seeks to make possible a good death. The Bishop argues that this biopsychosocio-spiritual medicine, because it's captive to the same metaphysics of efficient causation, turns out to deliver a kinder and gentler form of the same politics of efficient control, which, channeling his inner Foucault, Jeff describes as violence. Biopsychosocial spiritual medicine wields its control not through the techniques of manipulating the body as matter in motion, but through endless self-reifying assessments. I think we're all familiar with these assessments. Deploying the tools of statistical science, these assessments, by different disciplines, categorize all manner of human experience, naming the normal and the abnormal, mobilizing disciplinary powers to fix the latter, all putatively for the patient's good. These discourses of expert care recreate the very thing that they purport only to promote, Bishop writes, namely a good death. A good death is one that is managed in all its facets by those whose expertise defines a good death. Let me take hospice care, for example, a system of care in which I practice medicine. Hospice aims to achieve broad and comprehensive goals such as quality of life and relief of suffering. And the breadth of these aims ostensibly requires systematic assessment and total management from a team of disciplinary experts. Yet to be justified, the discourses and practices of these experts must offer something more than physiological medicine, can provide, while also having legitimacy within the regnant regime of scientific medicine. To gain that legitimacy, these disciplinary assessments have come to promise an extended version of the clinical gaze. So much as the clinical gaze penetrates the surface of the living body, these disciplinary assessments promise to penetrate the surface of what the patient and the family and the friends can tell. This pretense to naming and managing death becomes most ironic when it is extended to spiritual care, where biopsychosocial spiritual medicine reaches out to define what is good spiritual experience and to discipline and order even the clergy, to tell them when and how they can be useful. The result, Bishop argues, is that whereas the care of the dying, the ill, and the poor was once a handmaiden to the theological virtue of hospitality, now spirituality becomes the professionalized domain of a totalizing medicine. So in Bishop's account, the brute physiological medicine of the ICU and the holistic care of biopsychosocial spiritual medicine that purports to be its antidote are two offspring of the same parents, a metaphysics of efficient causation and a politics of efficient control. Medicine moves fluidly from the physiological medicine of the ICU to the statistical medicine of the biopsychosocial spiritual care, but both are experienced as powerfully organizing and controlling the way patients live and die, yet neither presumes to be guided by any meaning or purpose that might be derived from the sort of beings humans are. Humans are meaning-seeking animals. This vacuum of meaning must be filled. How can it be filled, though, without appeal to some formal or final cause, without appeal to some intrinsic meaning of embodied life? The answer, Bishop argues, is that meaning must be added post hoc by virtue of decision. So the antidote to the meaningless efficient control of the ICU technological apparatus and biopsychosocial spiritual medicine is a third form of efficient control, the control exercised through sovereign choice. Here, Bishop diagnoses contemporary medicine's focus on patient choice and autonomy as an effort to sustain the mythos of the autonomous self giving order to all these machines and all these disciplines by taking control of them and directing them toward a purpose of the self's own choosing. But many patients, and particularly those in the ICU, cannot choose. Within a metaphysics of efficient causation, such patients occupy a no man's land between life and death, in which to not be able to decide is to not be able to give meaning. For without a decision, there can be no meaning in this matter that happens to remain in motion, or when the matter that comes to rest. For many, and on Bishop's account, particularly social liberals, this is life worse than death, and someone must stand in to choose death on behalf of the patient. Ultimately, Bishop argues, the mythos of the autonomous self giving order to death by choosing how to deploy the efficient causes of physiological medicine and biopsychosocial spiritual medicine remains merely a mythos. Cells and the medicine that acts on them are always controlled to a great extent by the external powers and imperatives. In a metaphysics of efficient causation, these powers and imperatives tend to compel the patient toward a good death, as a death that is controlled, efficient, and chosen, a death that does not cause too much trouble. Yet far from being managed and mastered through biopsychosocial spiritual medicine, through biopsychosocial spiritual control, death returns, in Bishop's words, with a vengeance. A paradigmatic expression of death's vengeance, he thinks, is that remaining alive itself becomes a question and a choice that's a terrible burden for the dying to bear. Now, in my final 2 minutes, let me just say a brief word about the argument, apply Jeff's thesis to the argument Frank Miller is about to advance, and which he and Bob Trug have advanced in their recent book. One of their arguments, namely that the traditional distinction between killing and allowing to die is without moral significance in the realm of medicine, specifically the significance of the distinction between withdrawal and life-sustaining treatment and directly acting to cause someone's death. I think Bishop is correct to say that Frank's argument exemplifies and depends on a metaphysics of efficient causation, and here is why, very briefly. First of all, I'd say I think it's clear that it's a metaphysical, that this is an issue of metaphysics, in that despite a millennia-old counter-argument, the idea of the rule of double effect, of intention making a big difference in our actions, Miller and Trug advanced this argument as if it's it's pretty obvious that it's proven the ethical case by showing that removing a ventilator is just as much in a series of efficient causes and effects that result in death as is, let's say, a lethal injection. And I think it makes clear that the idea of formal and final causes are treated as more or less morally irrelevant. But just to highlight briefly the old argument and how it stands, which does depend on at least the idea of a formal and final cause for the action itself. The only sense in which removing a ventilator causes death is the sense of efficient causation. It stands in a line of efficient causes and effects that result in a dead patient. Material cause is not relevant to such a case, but the action can't be said to be a formal cause of death, because nothing about the action itself defines it as death-causing. Removing a ventilator is not in itself a death-causing action, as all of us in this room who are not ventilated, and even Karen Ann Quinlan's parents, interestingly, can attest. And the action by the physician is not, or shouldn't be, and is certainly not necessarily intended to cause death. This can be seen by asking the physician beforehand, what is your plan of action? It seems obvious that a physician's plan need not include making the patient dead. To put it a different way, if the patient on the ventilator were to continue breathing on her own after removal of the vent, would it be reasonable to say that the doctor has failed to do what the doctor intended? I think it's obvious the answer is no, or certainly can and should be no. This is different from, say, a lethal injection. A lethal injection causes death in all three relevant senses of causation. Efficiently, it stands in part of the chain of causes and effects. I will continue later. Oh, thank you.